kidney disease patients, and severe hypertensive crisis. What are the components of therapy? It includes initial stabilization, includes airway assessment for adequate oxygenation ventilation. In this, most important part is using a non-invasive ventilation, which is a BiPAP support. It is very helpful in managing patients with acute decompensated heart failure who have decreased oxygenation. Vital sign assessment, continuous cardiac monitoring, which includes continuous ECG monitoring, blood pressure monitoring, charting, making the patient sit upright at least 35 to 40 degree, diuretic therapy, vasodilators, and urine output monitoring, which may require Foley's catheterization also. Patients with pulmonary edema due to hypertension normally need a vasodilator therapy. Patients with normotension and volume overload need a diuretic or plus minus vasodilator therapy, and patients with hypotension and intravascular overload will need diuretics and plus minus inotropes. Supplemental oxygen is given with either a non-rebreathing face mask, which delivers high flow oxygen up to 15 liters per minute. If patient is tachypneic, has respiratory acidosis, hypoxic, then non-invasive ventilation can be used. It has really helps these patients and prevents them from being intubated. Very rarely these patients need to be intubated, and the only indication is when they undergo cardiogenic shock or may have an underlying septic shock also. Diuretics. Patients with acute decompensated heart failure and volume overload, regardless of the etiology, should be treated with IV diuretics. The rare exceptions are if a patient has cardiogenic shock, as I shared. IV is preferred overall because of the faster onset of action and greater bioavailability. The common drugs which are used is furosemide, bumetanide, and torsemide. Monitoring has to be done, which includes assessing of volume status, any evidence of congestion. You can see the JVP if it is elevated, oxygenation levels, daily weight measurement, and intake output should be strict. How much patient take through orally, everything has to be very strictly monitored in these patients. The diuretics, if given excessively, can increase your uric acid levels and precipitate gout if you are predisposed to it. So, monitoring potassium and magnesium levels at least once daily is important because when you're giving high dose diuretics, urine output will be high and they have can develop hypokalemia and which can also precipitate arrhythmia in these patients. That is why monitoring the potassium electrolytes level is very important. And also they can also develop increased serum creatinine because of side effect of diuretic as well as because of what we call as a cardiorenal syndrome, in which because of the high venous return, the kidneys get congested, and that can also increase the creatinine level. So important thing is that sodium intake should be restricted to less than 2 grams daily, doubling the diuretic dose till the diuresis. So we are trying to always try to achieve a negative fluid balance in these patients, at least 700 to 800 ml or sometimes even 1000 ml. All depends how much overload is there. Whether there is only because in acute failure, a lot of time you may not see pedal edema. It is more in chronic failure you will see pedal edema. In acute heart failure, mostly lung congestion is there. And if a patient has a chronic heart failure with underlying kidney problem, yes, then higher dose of diuretics are required, and fluid balance is a challenge thing. And you are trying to achieve more higher negative balance of around like maybe 1 liter. So all depends upon the body weight, how much fluid you want to remove from the patient per day. In some patients, the second diuretics can have to be also added if the first diuretic is inadequate, like spironolactone or chlorothiazide. Spironolactone has a mortality benefit also in patients with acute heart failure, and it has been proven. It prevents hypokalemia also. So it is a very frequently used drug in patients with acute heart failure. Aldosterone antagonist, which is spironolactone, recommended in patients with systolic heart failure. Vasodilator therapy includes IV vasodilators and diuretics are recommended in patients with acute pulmonary edema or severe hypertension. Frequent monitoring should be done because they can cause hypertension. IV nitroprusside, nitroglycerin, or necessitide, which is a brain natriuretic peptide analog, are used. Most commonly, you will use this nitroglycerin (NDG). So always NDG should be given through a broad gauge cannula, which is an 18 gauge. Peripheral veins, so we should be careful. It can cause thrombophlebitis. So and it is given initial dose of 5 to 10 mics per minute, and dose can be increased by 5 to 10 every 3 to 5 minutes, depending on your blood pressure targets. Normally, with blood pressure targets decreasing is around 15 to 20%. in the first 24 hours. Then IV nitroprusside initial dose is 5 to 10 mcg per minute. With nitroprusside, you have to be more careful in covering when you are giving this because it rapidly decomposes if exposed to light, and chances of cyanide toxicity are more also. So, and these drugs develop a tolerance also after 12 to 24, maximum 24 hours. Their effect weaks. The dose are titrated to maintain this is a systolic BP of 90, or depending on the patient, you will target around 120 to 130. Additional therapy are ACE inhibitors and angiotensin receptor blockers, which are discontinued if patient has hypertension, hyperkalemia, acute renal failure, or having a persistent cough also. Other inotropic agents helpful in these patients with LV systolic dysfunction and low output syndrome. Frequent BP monitoring, and at least once or twice, ECG should be done for monitoring of cardiac rhythm. Symptomatic hypotension or tachyarrhythmias are contraindicated, or contraindications for giving these drugs. Another drug which is used as inodilator is milrinone. Loading dose is 50 mics per kg over 10 minutes. The maintenance doses of 0.375 to zero point 0.7 mics per kg per minute. Dobutamine is another drug, which is inodilator. It is used to increase the contractility of the heart, but should not be used if a patient has an ongoing acute MI. So in that you have to be careful. Also, if a patient has hypotension, its systolic BP less than 100, it can cause hypotension, worsening of the hypotension. Dopamine dose these days is hardly any use in case of acute decompensated heart failure. Vasopressor therapy is indicated with a patient with decompensated heart failure with shock. Basically, in cardiogenic shock, the first line of therapy is norepinephrine. No doubt about that. Even in septic shock, first line of norepinephrine, cardiogenic shock also norepinephrine is indicated. Dopamine very rarely used. Say, last line maybe vasopressin or adrenaline also can be used. Beta blockers indicate in patients with acute decompensated heart failure and systolic dysfunction. Venous thromboprophylaxis should be given either via low molecular heparin or fondaparinux. Morphine is used very in selective patients because you have to be careful with it can cause respiratory depression. But in acute heart failure, it helps in reducing anxiety, decreases the venous return by vasodilation, and helps in decreasing the filling pressure. So helpful in reducing the deoxygenation and pulmonary edema. Mechanical cardiac assist such as devices used are IABP or Impella. These are the mechanical devices which are used if a patient has a cardiogenic shock with poor contractility. So they have help in temporary phase till the heart function can recover. Or if a patient is having myocarditis, then also it can helpful in tiding over the time till the heart recovers. Ultrafiltration is used in some patients with acute decompensated heart failure when urine output is low, especially those patients on CKD or already on dialysis, in which you just remove the scuff, the ultrafiltrate. Thank you. Any questions?